Welcome, Professor. Your audience, let me explain, is a group of participants, co-participants who sit in front of you, lawyers to your left. Beyond this room, however, in a breakout room here and on YouTube and live stream, there is a rather larger audience which will number in at least 3 figures, I would expect. The questions are going to be asked by Ms. Fraser-Butlin in a moment or two, but first let Mary invite you to take the oath.
Please state your full name.
Ian Gray Roberts.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Yes.
Professor Roberts, you originally qualified as a paediatrician, becoming a member of the Royal College of Paediatricians in 1988. Is that right?
Yes.
And then you trained as an epidemiologist in New Zealand and Canada. And now you're a professor of epidemiology at the London School of Hygiene and Tropical Medicine.
Correct.
Can you explain for us what that role entails? What is a professor of epidemiology?
So epidemiology is the study of disease occurrence, and it's mainly about research to identify the causes of disease and countermeasures for disease. I particularly focus on clinical trials, which is the way we find out, the way we identify safe and effective medicines.
And you've provided the inquiry with a statement about the role of tranexamic acid to reduce bleeding.
Yes.
Particularly in surgery and trauma. You've been involved in a number of studies showing the benefits of tranexamic acid, but I want to just turn to one particularly recent study, RLIT 301825. It's an article from April 2022 in the New England Journal of Medicine, dealing with something called the POISE-3 work. Can you tell us what the POISE-3 work is?
Okay, so just a minor clarification first. I was involved in this study, but in a relatively minor way. I've led several large-scale trials of tranexamic acid in bleeding, but not this one. But
it's right, isn't it, that this article builds on many of your previous studies?
Absolutely, absolutely.
And the article that I'm going to go through summarises quite a lot of the research that you had already done.
It does.
So in this study, if we look at methods, we can see that this, sorry, just up a bit, Lawrence, we can see that this was a trial involving patients undergoing non-cardiac surgery. Can you tell us a little bit more about what was being done in this study?
Okay, so this is something called a randomized controlled trial. The best way, the most valid way to find out the effects of an intervention are to get a large group of patients and to randomly allocate them to get the test treatment or the placebo or other comparator. And neither the patient nor the doctor making the assessments of outcomes know what the patient received until the end when you crack the code. Now, this randomization is really special, and it's what makes this study very important, because if you randomly allocate patients to get the treatment or not, you get 2 groups that are identical in their prognosis apart from the treatment, so that any differences in outcome can be attributed to the treatment.
And if we look at the abstract under the heading methods, we see a summary. If you can, yeah, thank you. The primary safety outcome the primary efficacy outcome was life-threatening bleeding, major bleeding, or bleeding into a critical organ, composite bleeding outcome at 30 days. And the primary safety outcome was myocardial injury after non-cardiac surgery, non-hemorrhagic stroke, peripheral arterial thrombosis, or symptomatic proximal venous thromboembolism at 30 days. So what was this study assessing in terms of risks and benefits?
Yes, it was assessing the risks and benefits of a drug called tranexamic acid, which reduces bleeding. That's its mechanism of action. And do you want me to summarise what they found?
Yes, please.
So at the end of the trial, when they cracked the code, they found that patients who received tranexamic acid had significantly less of these major bleeding episodes. I think it was a 25% reduction, thereabouts, in the risk of major bleeding. But you've obviously got to think of, whether there are potential adverse effects as well. And there was no statistically significant increase in the risk of unwanted thrombosis. So on aggregate, this trial showed that tranexamic acid reduces bleeding without increasing the risk of unwanted side effects. And the result is exactly in keeping with a very large body of evidence that has shown this previously. So it's kind of confirmatory. It's not news, really.
And that's the part of the article I want to go to, page 9 of the article under discussion. We pick up at the bottom of this page. Large trials have shown that tranexamic acid, as compared with placebo, is associated with a lower risk of death due to bleeding among patients with postpartum hemorrhage and a lower risk of death among patients with trauma. Large surgical trials have shown that tranexamic acid resulted in a lower incidence of postpartum hemorrhage among patients undergoing caesarean section and a lower incidence of hemorrhage resulting in reoperation among patients undergoing cardiac surgery than placebo.
May I just ask a question? I want to suggest to you a somewhat basic lay understanding of what tranexamic acid does. The clotting process in the body naturally permits the fibrinogen within the body to form fibrin, which acts in strands to plug a leak from any blood vessel. Is that basically right?
That's right, yes.
The process, of course, is one which liberates the substance which causes the clot. And therefore there has to be some process which stops it going too far and clotting the blood vessel, which would obviously have the effect of causing a thrombosis. So you'd have both, you have a plugged leak, but you create other problems. Is that also right?
It's very difficult to say what the body really wants, what the body's intention was. All of these physiological processes have sort of evolved on the anvil of natural selection. But what we do know is that whenever a blood vessel is ruptured or cut, it stimulates two processes. One is clot formation, and the other is clot breakdown. And tranexamic acid inhibits the latter process. So you're absolutely right. These fibrin strands are like a sort of a mesh of, you can imagine it's like spaghetti or something like that. Well, there's an enzyme in the blood called plasmin that just chops up the spaghetti into little pieces. And tranexamic acid inhibits that enzyme. So it sort of helps the body's endogenous clotting process.
So by stopping or hindering the natural breakdown of the clot by this process, it allows the clot to stay in place.
Correct.
And therefore, the body is, as it were, more likely to clot successfully.
Correct.
And the worry would then be, presumably, that by stopping this breakdown process, you may be creating the problem of actually plugging the vessel itself.
Absolutely.
Which is why you're worried about thrombosis.
Yes.
So what your study is showing is that it helps to preserve a clot where it's necessary without creating the side effects of additional thrombosis.
Exactly, that's correct.
In terms of this body of other studies, several of them have been your studies looking at the role of tranexamic acid in other contexts. Is that right?
Yes.
And this may have already been addressed with the judge, but could you explain in layman's terms what the benefits of tranexamic acid are in particular contexts? So the first context I've been asked to explore with you is in the context of childbirth.
Yeah.
The figures suggest a significant lowering of the incidence of postpartum hemorrhage. Can you explain for a layperson how that works?
So severe bleeding after childbirth is a leading cause of death worldwide. Something like 70,000 women die every year from this. You know, they deliver their babies, they start bleeding, and they continue bleeding, and they die. And so finding safe and effective treatments for postpartum hemorrhage is obviously a priority. We did a large clinical trial called the Woman Trial, where we randomly allocated 20,000 patients, 10,000 to get tranexamic acid, 10,000 to get placebo, and we found a statistically lower risk of death due to bleeding. Postpartum hemorrhage death was lower in the group that got tranexamic acid, and not with, bearing in mind the concerns that we might be causing other problems, we found no increase in the risk of unwanted clotting.
And in terms of malignant conditions which require blood transfusions, something like a leukemia or a lymphoma where patients require blood transfusions, does tranexamic acid have any role to play in the management of those conditions?
That's much less clear. So there have been a few randomized trials. I'm not completely au fait with the results, but it's not generally regarded as an indication for tranexamic acid. So the mechanisms, there's a sort of similar mechanism of bleeding between surgery, trauma, and postpartum hemorrhage. It generally involves, cutting or tearing of flesh, but the bleeding you get in some malignant conditions might have a different mechanism.
And then in terms of a third mechanism, in terms of those with bleeding disorders, haemophilia or A or B or von Willebrand's, does tranexamic acid have any role to play in those conditions? Have there been any studies in that context?
It does. In fact, the thing that tranexamic acid is licensed for, because it was licensed many years ago, but it's licensed for the treatment of patients with haemophilia undergoing tooth extraction, for example, and for the treatment of heavy menstrual periods. So a patient with haemophilia who's having surgery should benefit from tranexamic acid just the same as a patient without haemophilia having surgery.
And so your work, is this fair, has been focused on the trauma, surgery, childbirth context and the use of tranexamic acid in those situations?
Correct.
And what your work has shown, I think, is a significant improvement of outcome with the use of tranexamic acid.
Yes.
And if we just go back to this article
Yep.
and look at just further down on the page, on the right-hand side, we see the paragraph starting, patients prefer to avoid bleeding and transfusions. Although tranexamic acid can facilitate these goals, only a small proportion of patients undergoing non-cardiac surgery receive it. There's an annual global shortage of 30 million blood product units, and surgical bleeding accounts for up to 40% of all transfusions. Given that 300 million surgeries occur annually worldwide, the results of the POISE-3 trial indicate the potential for large public health and clinical benefits if tranexamic acid becomes standard practice in non-cardiac surgery. Strengths of the trial include the participation of 114 hospitals across 6 continents, and there was obviously high adherence and blinding. You've described in your statement that the guidelines and quality standards that we're going to look at in a moment, if they were complied with, it would prevent over 15,000 major surgical bleeds. Is that right?
That's our estimate, yes.
And approximately how many units of blood per year would then be saved?
We estimated 33,000 units of blood. It was a very, it's an estimate, and all estimates involve, assumptions, some of them quite, contestable, I guess.
Can you explain for us how you got to those figures? What were the assumptions and the estimates that you used?
I was hoping you wouldn't. I've got some notes here about that. But from memory, there's about 1.5 million units of red cells used in the NHS each year. And about a third, I think it was 27%, are used in surgery. So we've got this lump of red cells that are used in surgery. And so tranexamic acid reduces the need for blood transfusion by about a third to a quarter. And so you can say, well, a third or a quarter of that amount estimates to this amount of saving. That's roughly the structure of the estimate.
And the use of tranexamic acid is in various guidelines.
Yes. Could
Could we go through those? And then I want to ask you a bit more about them. Could we turn to RLIT 301793, please? This is a NICE guideline published in November 2015, and if we turn on to page 6, we can see that key priorities for implementation. The following recommendations have been identified as priorities for implementation. And then if we go down to cell salvage and tranexamic acid, it says offer tranexamic acid to adults undergoing surgery who are expected to have at least moderate blood loss, greater than 500 ml. For advice using tranexamic acid, then there's a NICE guideline on the particular context of joint replacement. And if we turn on to page 10, we pick up the recommendations section, and again we see under the heading cell salvage and tranexamic acid, offer tranexamic acid to adults undergoing surgery who are expected to have at least moderate blood loss, greater than 500 millilitres, and then consider tranexamic acid for children undergoing surgery who are expected to have at least moderate blood loss, greater than 10% blood volume. And then if we carry on to page 22, we have a bit more detail.
Yes.
The challenge, using tranexamic acid as an alternative to transfusion. Hospitals may improve clinical outcomes and cut costs by reducing the need for blood transfusions with their associated risks whenever possible. Tranexamic acid is an inexpensive antifibrinolytic pharmacological agent that can be administered before and during surgery to reduce bleeding and therefore the need for blood transfusions. There is strong evidence that this is clinically effective and that its use will reduce mortality and costs. Reducing variation in practice, clinicians are not consistently offering tranexamic acid to adults undergoing surgery who are expected to have at least moderate blood loss, greater than 500 millilitres. Clinical opinion is that current usage may be as low as 10 to 20%. This may be due to a lack of awareness and of inclusion in local clinical protocols. Just pausing there, this guideline is obviously from 2015. Does that sort of usage figure fit with your understanding in that time frame of about 2015, that it was as low as 10 to 20%?
Yes. I haven't done any, I didn't do any surveys of the extent that it was used, but I've got no reason not to believe these estimates here.
And then the guideline continues to say to promote its use, medical directors and hospital transfusion committees could, and then they provide 3 different tools, algorithms and statements to encourage compliance. What's your understanding of how these tools encourage the use of tranexamic acid? What's the point of them within the hospital context?
Could we have a look at the other two?
My apologies, sir, I thought it was on the screen. That's the next page. There it is. The use of the NICE guideline algorithm and the use of the NICE costing statement to estimate possible cost savings. what's your understanding of how these tools and algorithms might encourage the use of tranexamic acid?
I wouldn't hold out too much hope for them. That's my opinion. I think you have to do a lot more. Changing clinical practice is really hard. And so you have to use all the levers at your disposal.
Let me pick up the other two policy statements, and then I want to come back to that question of encouraging compliance. RLIT 301794, please, which is a nice quality standard. And we see the date of publication, 15th of December 2016, and if we turn to page 4, we see the quality statement. Adults who are having surgery and expected to have moderate blood loss are offered tranexamic acid. Statement 2. And then if we turn to page 8, the detail is provided. The quality statement is repeated, and then rationale. Tranexamic acid can reduce the need for blood transfusion in adults having surgery. This avoids serious risks associated with blood transfusion, for example, infection, fluid overload, and incorrect blood transfusions being given. It may also reduce the length of hospital stays and the cost to the NHS. And then quality measures, structure, evidence of local arrangements to ensure that adults who are having surgery and are expected to have moderate blood loss are offered tranexamic acid. And the data source, effectively to evidence that the quality measure has been met, is local data collection, and a process is explained of the proportion of adults who are having surgery and are expected to have moderate blood loss who receive tranexamic acid. And so the numerator is the number of adults in the denominator who receive tranexamic acid, and the denominator is the number of adults who are having surgery and are expected to have moderate blood loss. And then if we turn to the next page, there's an explanation of what the quality statement means for different audiences. Service providers, secondary care services, ensure that systems are in place to offer tranexamic acid to adults who are having surgery and are expected to have moderate blood loss. Healthcare professionals, doctors, nurses and blood transfusion specialists offer tranexamic acid to adults who are having surgery and are expected to have moderate blood loss. Commissioners, clinical commissioning groups, commission services that offer tranexamic acid to adults who are having surgery and are expected to have moderate blood loss. Adults who are expected to lose more than half a litre of blood during an operation are offered tranexamic acid. This helps blood to clot better and reduces blood loss during surgery. In terms of this quality standard, is it right that the idea is that there's a quality standard that clinicians, commissioners are all expected to comply with, and data is provided to prove that compliance?
That's my understanding, yes.
And then and we'll discuss compliance in a moment, if we then turn to RLIT 301824, we have the NHSBT National Comparative Audit of Blood Transfusion 2021 National Comparative Audit in relation to the NICE quality standard. And if we turn on to page 4, we see quality statement number 2, adults who are having surgery and expected to have moderate blood loss receive tranexamic acid. And then we have the audit findings. The audit found that 1,079 out of 1,599, 67.5% eligible surgical patients were given tranexamic acid, while potentially all were eligible to receive it. So in terms of the audit findings, that's an improvement since 2015, where it was thought to be 10 or 20%. In terms of surgical patients, it's gone up to 67.5%. I've been asked to ask whether you're aware of any analysis that assesses the non-compliance with NICE guidelines and clinical standards in terms of the sex, age, or race or region of the UK of the patients involved?
I'm not aware of any study of non-compliance along the lines you suggest. No.
Even with compliance of 67.5%, it might be suggested that there is still work to be done on encouraging compliance. Can you help us with your understanding of the difficulties in achieving compliance with the quality standard, particularly in tranexamic acid?
Okay. First, I would say that the NICE guideline was developed in something like 2014 or published in 2015, I think. It's since then a lot of evidence has accumulated about the safety and effectiveness of tranexamic acid. So I think the NICE guideline itself is very conservative, that actually the population who would benefit from this drug is much wider than that implied by the kind of inclusion criteria for this guideline.
And who would you expand that to? Who would you say the population should be that it applies to?
Well, patients who are at risk of a blood transfusion. I mean, if I had surgery and woke up to find I'd received blood and I hadn't been given tranexamic acid, I'd be really annoyed. And so I think this, I think we could do better. I personally think a wider range of patients should be included. And that's why, perhaps we're going to talk about this later, but in this recommendation that we established a group with the Royal Colleges, and we recommended that tranexamic acid should be considered in all patients having inpatient surgery. Not that they should necessarily receive it, because obviously, you know, you'd have to have a process of shared decision-making with the patient, but they should be offered it. And
can you tell us about the establishment of that implementation group, how it came about and who is part of it?
Okay, so when the POISE trial result was published, I wasn't surprised about the results because there'd been so many previous studies that had shown exactly the same. But I felt, well, we've really got to, you know, doing more research. Now, this is something that we really know, and we've got to make sure it's properly implemented. And then I had some conversations with NHSBT, Mike Murphy in particular, and he told me about this audit. And so we had overwhelming evidence of safety and effectiveness. We had strong indications of inadequate compliance, so we decided to try and do something about it. And so we kind of formed an ad hoc group with representation from the Royal College of Surgeons of England, the Royal College of Anaesthetists, and the Royal College of Physicians. And we wrote an editorial. We said we're going to try and, you know, the status quo isn't adequate, and we're going to try and change things. And we, you know, made some suggestions of what we think needed to be done, and we're still in the process of trying to carry those things out.
And can you tell us what you have done so far to try and increase compliance?
So, first of all, to make surgeons and anaesthetists aware of the evidence for the safety and effectiveness of tranexamic acid. So we've got, so the Royal Colleges have put out some statements on their websites. We've got a webinar for surgeons and anaesthetists. I think that's next week. So raising awareness that way. We wanted it to be included in the safe surgery checklist. So when a patient's in the operating room about to have surgery, there are often checklists that people go through. You know, is this the right leg that we're operating on? You know, is this the right patient, right leg? Is there any? And so, you know, should this patient receive tranexamic acid, we felt should be considered at that time. The next is whether we could establish what's called a CQUIN. So there's a system within the NHS whereby hospitals are incentivized for providing best practice. And so I think it's a financial incentive for a certain proportion of patients. It could be that, like in the NICE guideline, perhaps 90% of patients were treated as recommended by the NICE guideline. So we tried to get a CQUIN established for tranexamic acid in surgery.
And a CQUIN is a commissioning for quality and improvement quality indicator.
Thank you.
And that's dealt with by NHS England and NHS Improvement.
Yes.
Is that right?
Yeah, I believe so, yeah.
So let's just pause on CQUINs for a moment. There would be a financial incentive if a certain percentage of patients were offered tranexamic acid. What's the sense of the group in terms of the difference that makes in practice on the ground in a hospital?
Hospitals respond to financial incentives. After we identified that tranexamic acid reduces the risk of bleeding to death in trauma patients, we worked with people in NHS England to establish a trauma tranexamic acid CQUIN. And later down the track, we looked at that. The extent to which it's been effective, and I found it to be surprisingly effective. So my impression is that people do respond to financial incentives.
Another form of measure you suggested was tranexamic acid being included on the safe surgery checklist. Who decides what's on a safe surgery checklist within a hospital?
Well, the safe surgical checklist operates at a number of levels. It's a kind of WHO, World Health Organization initiative. So we wrote to the WHO and asked them to consider the inclusion of tranexamic acid on the safe surgical checklist. It's implemented in all NHS trusts. I think that's their own decision. I think that's their internal processes. I mean, it should be able to be influenced by NHS England, high command or whatever the term is, but I think it's the decision of all individual trusts.
And you've said in your statement that one of the difficulties in terms of compliance is that there are no sanctions for non-compliance. Do you think that sanctions in some form would be effective in ensuring compliance?
Yes, I think they probably should do. I think, if you've got something that's the standard of care and a patient doesn't receive it and it's picked up in audit, I think then you need to close the loop and say, look, you didn't give tranexamic acid to this, or didn't offer tranexamic acid to this patient who could have benefited from it. Why not? And, have you got a good reason for this? And I think, that sort of feedback loop is part of improving medical care.
And in terms of sanctions, how would you see them working? Would they be on an individual level or would they be at a trust level? Very practically, how would sanctions operate?
They could be at all levels. So, with audit, the audit is carried out a lot in the NHS, and sometimes it's sort of league tables. So, look, your hospital trust was the lowest, had the lowest proportion of patients who were offered this safe and effective treatment. And that process of sort of showing everybody how they are doing compared to everybody else leads to a sort of, social pressure tendency for people to try and improve. But it's at all levels, really. It's at sort of the level of the institution, the level of the surgical unit, the level of the individual surgeon and staff.
So in terms of the position now, the implementation group have the sort of education element operating to encourage and educate clinicians to use it. But what's happened in terms of the sequin for surgery? Is that in place?
So I think it's important to point out that our group is a sort of ad hoc group and we don't have any resources at all. And so we asked NHS BT for resources, but they weren't able to provide any. So we're sort of, we weren't established by the NHS to improve compliance. We established ourselves to try and encourage the NHS to take action. Initially, all of our suggestions to the NHS were not they weren't met with any enthusiasm at all. The only thing that has made a difference is the recent blood shortage within the NHS. And so all the things that we said it should be doing, all of a sudden, they became suddenly interested in the work of our group.
I want to come to
Sorry,
that. Just one moment.
Yeah.
I just want to track back, in a sense, to that period of time when you were trying to engage people about the importance of tranexamic acid. And you've described in your statement that you had written to UK Ministers of Health, Chief Medical Officers, the Care Quality Commission, the WHO, and many others, you've said, over the last 2 decades about the use of tranexamic acid. Broadly, what was their response to your request for tranexamic acid to be considered more significantly? What was the response you tended to receive?
Negligible. Nothing. I don't think there's been any. I mustn't be too. I mustn't exaggerate, but I didn't really get much sense of interest in this issue.
And did you ever write to the MHRA that you can recall?
I don't think so. No.
In your statement, you've said that changing practice in the NHS is hard.
Yes.
Particularly, you said, because tranexamic acid is a cheap generic drug and there's no profit motive for pharmaceutical companies to promote and implement it. Can you explain for us what you were addressing there? What's the issue?
I think it's sort of, in economic terms, it's sort of market failure, really. It's that because when a pharmaceutical company has a drug and that it stands to make a lot of money out of it, it paves the way for the implementation of the drug. It makes sure that everybody knows about it. There will be conferences where that raise awareness about it. There will be key opinion leaders who will be speaking about it. They'll fly experts all the way around the world to talk about it. So there's a lot of money is spent to make sure that people know about it. And I'm sure there is, I would imagine there is, conversations with NICE about guidelines and their extent and so forth. And so there's a lot of activity that doesn't happen with an inexpensive generic drug that's made by lots of different companies. They don't make much profit out of it. So after the CRASH 2 trial, which showed that tranexamic acid was life-saving in trauma, I spent a lot of time lobbying Pfizer to include trauma on the list of licensed indications. And they were initially a bit lukewarm, and then I was pestering them and writing lots of letters. I even wrote to the President of the United States, and this goes on for a while, but eventually they decided not to. And my understanding of the reason that they didn't is that to change the licensed indication, they've got to make an application to the FDA or MHRA, and there's an application fee, and there's a certain cost involved in gathering all the information, and they make a kind of economic decision that the profit from doing that doesn't justify the cost. So So at the moment, the licensed indications for tranexamic acid don't really reflect the clinical evidence for its effectiveness and safety.
So if we put those two issues together, the economic question of a generic drug and the what you attempted to do by contacting lots of bodies, and your recollection is they didn't show much interest, do you have any views then of whether there's a structural issue in terms of how policies in relation to a drug like tranexamic acid, how policies are developed and implemented within the NHS?
Yes, there's definitely a structural issue. And in fact, now that you say that, I have had contact with the MHRA about the problem of the licensed indications not taking in all of the, so it doesn't have postpartum hemorrhage, trauma, elective surgery, and I have had some conversations with the MHRA about that.
And I'm asked by other legal representatives to ask you whether you consider that there is a need to, whether you have any thoughts on what a solution would be, whether there needs to be a new body or whether there needs to be a change in the structure so that it's clearer who has responsibility for the implementation of blood policy and medications in the NHS. Or whether that's not something
I just don't know. It's not my expertise. I don't know whether a new body would be better or worse than the existing bodies doing their job properly. I'm sorry about that.
You mentioned a moment ago that there had been very little interest in tranexamic acid until the recent blood shortage. Can you tell us a little bit more about which bodies have been in contact and what they've been exploring with you and what the issues have been?
So once the blood shortage became obvious, NHS England became much more interested in we managed to get the medical director of the NHS England to include mention of tranexamic acid in his newsletter to medical directors of NHS trusts. So that was one thing, I think, relatively small thing. They are now interested in developing a sequin, and we've had several back and forths about shoring up, a sequin, the wording of the sequin. There's some talk about including it in the safe surgical checklist, but that's a kind of work in progress as well. The blood shortage, as you know, is only very recent. It's only a couple of weeks ago, or possibly a month ago, that this amber alert became apparent. So I don't think there hasn't been an awful lot of time for much to happen. And
the final topic, returning to the patient view, in terms of giving tranexamic acid, would you agree that it's something that should be discussed with a patient and they should give consent to receiving it, first of all?
Yes, I do. I think the patients should give consent for blood transfusion, and part of that consent process has to include the possible alternatives to blood transfusion. And tranexamic acid would surely be on the list of possible alternatives. And so it should be discussed as part of the consent giving for blood transfusion. But also, patients should be involved in their care. And so, if the anaesthetist might meet the patient before the operation and say, look, these are the things. Patients don't give consent for every small thing, but, might lay out, what's broadly going to happen. And are you happy with that?
And I think what you're saying is that as part of the conversation about consent for a blood transfusion, alternatives to it, including tranexamic acid, should be a fundamental part of that.
I am saying that, yeah.
And finally, I'm asked to ask you whether you think that a database collecting data about every unit of blood given to a patient is something that you think should be established so that blood usage and the use of tranexamic acid can be monitored and determined.
There needs to be information is necessary for this audit loop, and so clearly I won't go into what hemovigilance mechanisms are, because I know there are many out there already, but we do need to collect information on what proportion of surgical patients receive tranexamic acid, so that we can close the sort of audit loop and hopefully improve care.
And that's an audit loop you already have in relation to trauma through the sequins.
It's not really the sequin thing is audit loop at one level, but not at all levels. So, you know, it could be at the level of individual hospital. You know, how many patients did we operate on this month? How much did they bleed? You know, what was their use of blood transfusion? How many of those patients were offered tranexamic acid? And I think that information would be helpful.
So those are the questions I have for Professor Roberts. I'm conscious I need to just explore whether the other legal representatives have additional questions they'd like me to ask him.
Yes, well, let me just explain to you, Professor. Those who have an interest in the inquiry, various different interests, are entitled through their legal representatives to ask counsel to address certain questions to you, which arise out of your evidence. Plainly, they may be, will probably have read your statement, but they will also now have heard what you've had to say in oral testimony, and that will be new to them. They may give rise to more questions for counsel to field. We must give them an opportunity to put those questions forward, for counsel to consider them, and for you to come back and answer them. It'll need a break. So how long a break do you think we might need?
I don't think I need very long, sir. Perhaps 10 minutes.
Well, let's take a quarter of an hour. So let's say not before 1:10. It may be longer than that if there are more questions. Then we'll come back and we'll see how many questions there are.
Okay.